It's a pleasure to be here. And I just want to start by thanking the hosts of this conference. I have been doing complementary and integrative care in Parkinson's for 20 years. And for the first 10 years that I was trying to get this conversation on the table, I felt like the first 10 years, the conventional community was not having any of it. There was rarely a conversation about complementary and integrative medicine. And in these past 10 years, in all of the conventional conferences, there's usually the token talk. There's the one talk on exercise among several on drugs and surgery. This is the first conference I've ever been a part of targeting the typical, normal Parkinson's community that really complementary integrative medicine, lifestyle management, advocacy are the new normal. The integrative approach seems to be kind of taking center stage here. So it is my hope that this conference represents a turn in how we talk about Parkinson's disease, how we treat it, and that this conference kind of brings in a new decade of integrative care where we practice personalized medicine and lifestyle management for people with Parkinson's disease. My disclosures are all will be available. You can go back and look through these. Nothing to do with nutrition that I'm going to be talking about today. I was asked to talk about natural therapies and nutritional requirements for people with Parkinson's. As Dr. Vega and Subramanian have already talked about today, natural therapies cover a lot of territory. It is, what does the human body need to function? Are there insults coming in? Physical activity and exercise, mindfulness, neuroplasticity, mental health, other paradigms. This can be a really long, expansive topic that is going to infiltrate what I'm talking about, but that's not really what I'm going to be mostly talking about today. My personal area of interest and expertise has more to do with the nutritional requirements for people with Parkinson's disease. So I think really what all of you want to know is there more that I can do above and beyond drugs and surgery? Most people feel like their bases are pretty well covered from their movement disorder doctor and their neurologist. I assume that what most people are here to learn is what else is available. So one of the biggest questions I get is when I tell people I study nutrition, they right away go to this idea of food. And I just want to stress before we move on that nutrition is so much more than food. The study of nutrition is really asking ourselves, what do we need to nourish ourselves? What does a human body need to not only survive, but thrive? We need to breathe, we need water, we need social connection in addition to calories. So this idea that nutrition is something much more than food is something that I'd like you to keep with you as we talk throughout today's conversation. In the field of nutrition, burn victims need more protein. Elderly people are more at risk of B12 deficiency. Growing children need more calories than adults. Pregnant women need more folic acid. We do know that at different stages of our lives, based on different conditions we find ourselves in, specifically diseases, that we have unique nutritional requirements. To date, nobody has attempted to describe what are the unique nutritional requirements of people with Parkinson's. And that's really what I've spent my career attempting to do. So a lot of times people will come in with this long list of supplements and I ask, why are you taking it? And they tell me they're taking it for Parkinson's. And I want to make sure that you all are aware of this distinction between treating symptoms and slowing progression. It doesn't mean that there can't be a medicine that does both. I mean, in a dream world, we'd have a medicine that does both, treat symptoms and slow progression. But if you look at this blue line as the expected rate of Parkinson's disease progression, we'll get into this graph in a minute in more detail, but this blue line through the center is what you would expect for rate of Parkinson's disease progression over time. A therapy that treats symptoms is not going to change the rate. You're going to progress at the same slope you otherwise would, but the symptoms will be better each step of the way. As opposed to something targeting disease modification, you may not notice symptomatic improvement at all, but what will happen is the longer you do it, the younger you start, the earlier you start, and the longer you live with this disease, the more those benefits pay off. And so the holy grail, what we've not been able to do in Parkinson's to date, is find disease-modifying therapies, ways to slow Parkinson's disease progression. And I really think that that is where nutrition and some of the things I'm going to talk about today are likely to shine. Here's what it would look like if you had a therapy that both reduced your symptoms and slowed progression. What you can see is that over time, the more years you live with Parkinson's disease, the more benefit you gain from these interventions. So a 95-year-old person or a 100-year-old person may not need to invest much energy into disease modification. Chances are they won't live long enough to experience the benefits. A 45, 50-year-old who plans on living for another 30, 40, 50 years really needs to focus on disease modification. And so even how physicians prioritize our counseling of you is influenced by who you are and what your particular goals are. So let's talk about what these scores mean. So what we have done is we have tried to develop an outcome measure that allows us to measure slope in symptom severity and rate of Parkinson's disease progression. So what we have done is built this scale. It's called the ProPD. Everybody can go get their own scores for free at the website propd.org, propd.org. And so it takes about 5 minutes to complete this scale. But what you do is you go through a list of 33 different symptoms of Parkinson's disease. And we ask you, on average, over the last 7 days, how severe have any of these symptoms been? If they've not been severe at all, no problem at all, you feel good, you slide the bar over to the left. Somewhere in the middle if they're moderate, and if they are severe and debilitating, you slide the tab all the way over to the right. And so the patient can go through fairly quickly and rate each of their symptoms. And then what we do is we add them up and give you a cumulative score. And what we have learned is that on average, when a new person is diagnosed, the average score of a newly diagnosed person is 580 points, and the typical rate of progression is about 38 to 40 points per year. Every one of these dots on this picture, the green dots that you see to the left, is a real person with Parkinson's. And so I'll talk about it in a minute, the diversity that we see here. But I just want to point out, in terms of getting the community on board with this scale, I think whether you are a clinician, a researcher, or a patient, I think everybody can agree that a score of 0 represents success. If patients can go through this list of 33 symptoms and say, in the last week, I have moved with ease, I have had healthy daily bowel movements, I walk comfortably, I have no freezing, no falling, no constant balance issues, no fatigue, we have succeeded. And so that's what we're working towards. How close to 0 can we get all of you? The other thing that I want to talk about here is, I said by the time you're diagnosed, you have a score of 580. One thing that I think doesn't get enough attention in Parkinson's disease is how late in the disease Parkinson's is diagnosed. We now know that by the time you are diagnosed with Parkinson's, you've already had this disease for 10 to 20 years. Early symptoms include loss of smell, acting out in your dreams, erectile dysfunction, constipation. When somebody's diagnosed, in hindsight, some of these symptoms start to make sense. But I think in the general population in primary care, we are doing a horrible job screening for people in their 40s and 50s who have already lost their sense of smell, who already may be acting out their dreams. I think if we can start to get to some of these people early and implement some of these changes that we're talking about here today, you can begin to reduce that slope even before you develop motor symptoms. That's really what we're looking for here. If we can get to people before they develop dopamine symptoms, initiate some of these disease-modifying strategies, we are literally opening the doors to prevention. So In what do we know about Parkinson's progression? I told you every one of these green dots represents a real person with Parkinson's disease. We have now surveyed over 2,600 people with different types of Parkinsonism. 1,700 of them have had idiopathic Parkinson's disease, and 850, I think, completed our survey just in this past year alone. So, what I really want to talk about is even though I keep talking about this slope, the average, what you can expect, this 40-point increase per year, what I want to draw your attention to is the diversity. There are people who are 10, 15, 20, 30 years post-diagnosis who are actually doing incredibly well with this disease. They barely have any symptoms, and they rate their quality of life as good or excellent. Conversely, there are people who are in the first 5 years of this disease, and they're highly symptomatic, and they're already rating their quality of life as poor. So what I have set out to do is to see if we can't find some of these people doing unusually well and see what they're doing different. As Dr. Bega already talked about today, the non-motor symptoms are often overlooked. The motor symptoms in Parkinson's disease get all of the attention, but what we see in our analysis is that 2/3 of the symptoms that people are reporting are non-motor symptoms. This is in part because we have really good medicines to hide the motor symptoms. If we took away your dopamine repletion strategies, I'm sure that the motor symptoms would be more severe. But what we see right now is that 2/3 of the symptoms that patients are reporting are non-motor symptoms, with fatigue, impaired handwriting, loss of smell, memory impairment, and muscle pain being among the biggest complaints of people with Parkinson's when we actually ask patients about their disease symptoms. So the heart of this research project that I've been working on for the last 7 years now is really simple. It is not rocket science at all. One of the things that has happened in research over the last several decades is that it has been very difficult to do double-blind, placebo-controlled research trials with so much diversity. You all know how every patient with Parkinsonism is a little bit different. You all have a different set of symptoms, a different set of concerns, are more or less responsive to medication. And all of that diversity makes it really hard to do a double-blind, placebo-controlled trial where we pretend that you're identical except for the red pill or the blue pill. And so the diversity in the field has really interfered with our ability to do research as normal. So what I wanted to do is find a better research methodology that would take advantage of the diversity in the field. And so what I've done is I designed this study where we follow people over the course of, it's been the last 6 years now. And what we're doing is looking to see who are the non-progressors and what are they doing differently than the fast progressors. It's called the positive deviance model. I did not come up with it. It comes from Tufts University. It's been used for a long time. It's just before now had never been applied to neurology. So for those who want to know what we've learned, each year we update this website, livinghealthywithparkinsons.com. We still have the 2020 updates on there right now, but any of you can go to this website after today's talk and see the summary slides of what we are learning. Everything that I'm about to talk to you about today, we have taken into account age, gender, years since diagnosis, and income. So we are trying our best to compare people just like you to try and get to the bottom of, are there things that people are doing that are improving or accelerating their rate of Parkinson's progression? Before I get into the answers, the results that we are discovering, I want to stress this type of study is, at least the analysis that we are doing, the way I'm presenting these data today, do not imply causation. I am not here telling you that A causes faster progression or B can slow it. All we are saying is that the people who are doing unusually well are clearly behaving differently than the people who are doing unusually poorly. So I cannot promise anybody that if you go home and you change your diet, that you will change the course of your disease. But I can tell you that the people who the slowest course of disease are eating very different foods than the people with fast progressing disease. So each one of you is going to have to make a decision. At what point is there enough data for you to feel confident that it's in your best interest to make some changes? And that's going to be different for every one of you. So as simple as it sounds, my advice is until we have a cure, until we clearly have a medicine that has been shown in double-blind placebo-controlled trials to slow, stop, or reverse Parkinson's disease, I'm going to suggest that you find the success stories, find the people who have your exact same diagnosis, and do what they're doing. Find the people who have your diagnosis and who are doing poorly, and don't do what they're doing. So before I get into the food, I just want to back up some of what was already spoken about today. Are using the same approach. What we are seeing is that the more exercise somebody does, the fewer Parkinson's symptoms they have. One thing that I think is really important to point out here, this is called a radar chart, and the bigger the bubble, the maple leaf, the plot, the more symptomatic a person is. As the area that is covered by this radar chart shrinks, so do people's symptoms get reduced. So we will be publishing these data later on this year, but what I want to show you today is that these data suggest that the first 2 days of exercise don't make a whole bunch of a difference in terms of reducing people's symptoms. Whether somebody does 0 days a week of exercise or 1 to 2 days a week of exercise, the orange line and the blue line, we actually don't see much difference. When people increase their exercise frequency to 3 to 5 days a week, we see the gray line, there's a notable reduction in symptoms. Over here on the right-hand side of the graph are most of the non-motor symptoms, and then we tried to clump the motor symptoms over on the left. And you can see that with 3 to 5 days a week, there is a notable reduction in both motor and non-motor symptoms. And those benefits get only better as one goes up to 6 to 7 days per week of exercise. So what we did is we asked, on how many of the last 7 days have you done at least 30 minutes of exercise? I am encouraging all of you to be in the cohort of people who answers that question with 6 to 7 days per week. Just make it your daily routine. As Dr. Subramanian talked about, social health is playing a major role in Parkinson's disease symptoms. We asked people a true or false question. I am lonely. People who said that they were lonely, people who answered true to that statement, were twice as symptomatic as people who said false. You'll notice the slope is not different. Lonely people do not progress faster than not lonely people, but they feel worse. They feel more symptomatic each step of the way. The other thing that I think we don't talk enough about is financial health. We asked all these questions about dietary behaviors. People who cook their own food and cook for others and avoid artificial sweeteners and try to eat organic all do better than people who say no, they don't do those things. What was surprising to us is one of the most significant predictors of Parkinson's disease rate of progression were people who reported that they had difficulty affording groceries and affording healthy food. That's kind of paradigm shifting. We have to give this a little more thought and start to wonder, could malnutrition be actually contributing to Parkinson's progression? Could it be the stress of being poor that is contributing to the disease? Maybe it has nothing to do with food. Maybe people who lack financial resources are getting worse care. This is not something that your clinician is going to be able to solve for you in a 30 or 60-minute visit even. This is a systemic global issue, poverty around the world. And, I just want to ask this philosophical question, could there be a day where patients actually receive a stipend to be able to join some exercise classes, afford healthier food instead of a pill or a surgery? Might there be a day where we could give patients a stipend as part of a therapeutic strategy? So now for the food part, I know that this is what a lot of you are most interested in. So far, the things that I've talked to you about, there are no big surprises. People who are doing the best have financial resources, they have a lot of friends, they exercise. That's not surprising. Now let's talk about food. And I will point out that I'm going to go through the good list and the bad list. And I have made this rating scale available to all of you. After today's talk, we'll make that available to you. But I just want to point out that not all good food is equally good. Not all bad food is equally bad. But for the purposes of you having something that you can take home and use, what I'm essentially going to do is tell you all of this food on the top half of the graph is associated with slower progression over time. I want you to load up on that, eat as much of that as possible. We don't know why, we don't know how, but we do know that the people who are doing best over time are eating large amounts, high quantities of this food on top, and they are avoiding the stuff on bottom. And that's what I'm going to ask all of you to do. So for today's analysis, what we did is we only looked at data from last year. That was 850 people in this data set. And the reason we only looked at last year is because we got better at asking questions. The first few years of the study, we did not ask questions about farro and quinoa and some of these grains that started to look good as look promising. So the big winner this year is news to me, farro. And barley, sorghum, quinoa, and buckwheat are actually all grains that are surprisingly associated with better outcomes over time, more so than even fruits and vegetables. This is not something I was expecting. I've spent a lot of time now these last 6 weeks since I've seen the data for the first time, trying to figure out what about these grains could be so good. They are high in something called fermentable fibers, which essentially don't get broken down through your small intestines. They save themselves up and they wait until they get to your large intestine, where they are food for the good bacteria in your large intestines. I've not grown up with farro. I wasn't familiar with farro. But I have to say, now that I've been exploring it and experimenting with it these last few weeks, I really enjoy it. It's a delicious grain. It's inexpensive. It's easy to find. You can turn it to soup, add it to salads. There are a lot of different ways to cook with it, but it's delicious. No big surprise here. The more fresh vegetables, fresh fruits, nuts and seeds, olive oil, coconut oil, non-fried fish, wine, beans, and fresh herbs a person eats, the better they do over time. As I said, no big surprises. At this point in my talk, most people are thinking, of course, duh, you wasted how many years doing this study only to tell us that friends and money and fruits and vegetables are good for us? Where we start, and this is very in line with what we see, these are the same foods that seem to be protective against Alzheimer's disease and even cardiovascular disease. These are very similar, these data independently look very similar to other healthy diets, like the Mediterranean diet, the MIND diet, vegan plus fish sort of thing. Where people start to run into issues is when I start talking about the foods associated with faster progression. Sometimes data is a hard pill to swallow, and I want all of you just to be aware of your own resistance to this, to what I'm about to talk to you about. If you don't love carrots, fine, you can eat more broccoli. It's easier to talk about where to get the good stuff. Where people start to have this knee-jerk resistance to what I'm about to say is when I start telling them that the foods that they love, that are part of their culture, that are part of their habit, that are part of their lifestyle, might be hurting them. And so I am not here to tell you you can never, ever eat these foods again. I'm just here to tell you that the people doing worst over time are statistically eating more of the foods on this list. We'll go through them one at a time, but this is the list of foods that are associated with faster Parkinson's disease progression. Canned food was a big surprise. When I started this study, I did not expect to see canned food being as bad for people as it seems to be. I thought, frankly, all green beans would be good, that fresh would be better than frozen, frozen would be better than canned, but all of them would be good. And that's not what we're seeing. We're actually seeing that vegetables and fruits and eating out of a can in general is one of these strongest associated factors with Parkinson's disease progression. We don't know if it is the lining in the can, the metals, we don't know what it is, but we're seeing these results fairly consistently. Fried food is not a big surprise. There is actually even some research that shows that there's a chemical that comes from fried food called acrolein that actually causes alpha-synuclein misfolding in research experiments. So that wasn't a surprise. There have now been several studies, nurses' health study, physician follow-up study that show the more meat, beef, chicken, and pork a person eats over the course of their life, the more likely they are to be diagnosed with Parkinson's. Our data also say that once diagnosed, the more meat a person eats, the faster their disease progresses. This will also make, reducing meat will also make your medication more available. And we see this in dairy. There have now been 5 studies that say the more dairy a person eats over the course of their life, the more likely they are to be diagnosed with Parkinson's. Our data says once diagnosed, the more dairy a person consumes, the faster their disease progresses. Soda, not really a surprise there. Both sugar-sweetened soda and diet soda are associated with faster Parkinson's progression. We don't know if it's the actual soda, it could be the cans or the plastic that people are drinking out of. Pasta is interesting. Pasta tends to come up on some of these lists and not other lists. And I am inclined to think that it might not be the pasta, but what we put on the pasta. Bread is not coming up on the list, so I don't think it's gluten. And interestingly, farro, remember I was just bragging about how fabulous farro was a minute ago. It is, of all the foods we looked at, farro is the most strongly associated with slower rates of Parkinson's progression. Farro contains gluten. So I don't think it's fair to say that you should be gluten-free. I don't think every one of you needs to be gluten-free, and I don't think it's gluten that is why we're seeing pasta on the bad list. I suspect it might be what we are doing with the pasta, adding cheese and adding canned tomatoes. So more research needs to be done. I'm not sure about this. When I'm giving you some ideas, I'm honestly guessing at why this might be. But we are seeing on the 2021 updated list that pasta is on the bad list. Juice is on the bad list. This is a little confusing. I mean, I was the one who designed the study. I wish I had asked this question differently. The more juice somebody consumes, the faster the rate of progression. I'm saying on here, surely the $12 glass of juice that I ordered from this organic vibrating cafe in Sedona is not the same as the prepackaged plastic tin-lined, highly processed, sometimes sugar-sweetened juices that you get at the gas station. But we don't know. I didn't ask the question the right way, so we can't tell the difference between impressively healthy juice or potentially bad juice. Drinking from plastic bottles is associated with faster Parkinson's disease progression. There's a little bit of research that bisphenol A is a chemical in plastics, might be contributing to Parkinson's disease. Obviously, a lot more research needs to be done on that. So those are the 2 lists of the good foods and the bad foods. And now we are all faced with this question about what do we do with this? How do providers begin to have this conversation with patients? How do we communicate? More is better. And, patients have questions about how much can I cheat? And, is a little teeny bit of chicken the same as a little teeny bit of ice cream, or is one worse than the other? And so we have a long way to go before we figure out what these data mean, whether or not if you change your diet, you will change progression. And mostly, how do we begin to have a conversation with patients about about in clinic. Clinic time is short, and providers are already difficult to get in with, to get put out the fires. It is really going to be difficult for neurologists to carve out time in their practice to begin to talk to patients about healthy eating. And dietitians have not been very well trained in Parkinson's disease to date. So we have this huge gap in unmet need in the community. So, in summary, I'm just going to say, until we have a cure, until we have some of these answers, it's not ideal from a scientifically designed study, but I will say I think it's one of the best approaches that we have to just look at thousands of people with Parkinson's disease, find the people who are doing best, and do what they're doing. In summary, I'm going to ask that you leave here today, go nurture your social relationships, make new friends. Don't be shy about reaching out and introducing yourself to new people. Not only are you helping yourself, you're helping somebody else. Exercise daily. Just make the 30 minutes a part of your life. Who cares if you miss the occasional day, but just make it a routine, like brushing your teeth, getting your 30 minutes in, and starting your day. Easier said than done, but prioritize financial stability. That is an important part of your overall sense of wellness and stress, minimizing stress. Eat a ton of fresh fruits, fresh vegetables, nuts, beans, seafood, non-fried seafood, water, olive oil, and whole grains. Farro, quinoa, sorghum, and buckwheat are the surprise winners in this new data analysis. And even though I don't know why, I'm going to advise that you avoid cans, plastic bottles, fresh fried food, meat, dairy, soda, and pasta. Thank you again for the invitation to be here today. And for those who may want additional information, feel free to check out our online Parkinson's School or the week-long intensive camp at Bastyr University that we host every year. Thank you very much.